Okay, moving on. We are going to hear about robotic surgery next, and I would like to welcome our speaker, Dr. Robert Cerfolio. He is a professor in the Department of Cardiothoracic Surgery and the director of the Lung Cancer Center at Perlmutter Cancer Center.
How are you guys doing? You need a stretch? You do? Take it. So it's an honor for me to be here. Let's try to make this fun and interactive. I like to walk around when I talk. That'll keep you more likely to be awake. I usually ask questions, so don't worry, they won't be technical. Financial disclosures. Every time I talk, I have to put these up because I have a company that consults. I talk to a lot of people, and the more people I talk to, the more I learn, and even better, the more I get paid, and I have to disclose it. So I'm a consultant for all three companies that make the robot, and also a company that coaches. I coach 12 surgeons. We look at videos and coach them. That's a lot of fun. I have a consulting firm, consultant for CHS that owns 220 hospitals for efficiency, and I've written a book, and because everything I cover is in my book, I have to disclose my book, so I use it now as a time for you to buy it. You can get your phone out now, go on Amazon.com. And I have a second and third book, and I have the covers of this. So I'd like Lean and Gaitan to tell me if they like this cover, if they think it's too busy. I think it's a little busy, don't you? Yeah, so you wouldn't buy this book if you saw it, would you? Geez, you hate when you have to say no so damn fast. Can we at least consider it? So what is too busy about it? The puzzle pieces? So I designed the light bulbs, but okay, I'll take them out. What else don't you like about it? It's got to be a little bit worried because solving the U.S. healthcare crisis, I don't know. What is it? Yeah, well, no, we can't, but hopefully the book gives some ideas. Actually, the key is this. It's aligning stakeholders. And we're not in healthcare. The patients don't have enough at risk. They need to have more for their decisions that they make. The doctors only get paid when the patients get sick. It should be the opposite. We should get paid when you don't get sick. Healthcare payers only pay. They don't want you to get sick, and otherwise they take your money. It should be the opposite that way. And once we get aligned, we will fix it. That's a culture change. And because it's a culture change, I'm going to talk a lot about culture, and I'm not going to get too technical. Go ahead. You should get your money back. In fact, actually, we should pay you. You should get either some of your money. You should never pay money. You should get money back not to get sick. And the doctors, if I stopped you from smoking or reduced smoking, that's how I should get paid as a lung surgeon, not to take your lung cancer out. I'm not aligned for you to be healthy. I'm aligned for you to get sick. I only get paid by operating. Now, actually, I don't. I have a different contract here, but most surgeons get paid to operate. So if you think about it, I'm not incentivized for you to be healthy. So I'm not saying that money dictates what people do, but there's always in the back of your mind, that's part of it. And so that's part of it. How about this book cover? This is my second book. You like this better? This is so funny because the polling we did, okay. So this is about leadership from operating rooms and highly functional operating rooms. I'm honored that we've had more people come to see our operating room than any other operating room in the world. We actually have data for that. We've had over 59 surgeons and their teams come now to watch us. I'm extremely proud of that. They don't just come to watch because we've done the most robotic operations or lung cancer operations in the world. They really come to watch that. And that is how surgeons don't yell at their teammates because we're immature, how we don't get irritated at our teammates because we're self-centered, how we don't hog resources because we're egocentric. I can go on and tell you all the bad qualities of surgeons, but I see Audrey nodding because she knows it's true. So, I can always go to kindergarten or first grade and I can look in the sandbox and I see the kid who's stealing everybody's truck and oh, there's your surgeon. There's your next surgeon. And then I can see the guy who's saying, oh, come over and play with me. Enjoy my toys. And that's the oncologist and the pulmonologist. And so the problem is we've got to work on our leadership skills because we are the worst of the worst. In any event, robot. So when people think about the robot and robotic surgery, they think about this. They think that this is what our future is going to look like. Does anybody here want a robot operating on them? Well, wait a minute. But what if the space shuttle lands without a pilot? The pilot just sat there so we could have a parade. He did nothing. That's all true. There'll be less mistakes. You don't have to worry about them being emotionally insecure. They're not going to treat their teammates poorly. They're going to treat them great. They're going to perform better. You sure? If I could tell a robot exactly where the artery and the vein is, and I could have them every single time get around it perfectly, why wouldn't you want a robot to do it? You want a surgeon there just in case? Yes. Just like the space shuttle, just so someone gets the credit and charges the hell out of you? In case there's a malfunction. Well, you have a backup and a backup system. What if the person malfunctions? I submit to you that's more common. So I'm working with a few companies that do this. This is actually incredible. I got a email yesterday from another surgeon who heard that I'm doing this and think that I'm doing a disservice to surgeons and that I should be copywriting my hand movements. What do I mean? So one robotic company is using my hand movements for an operation because I'm sitting on a console robotically and everything's tracked. It's really a computerized system. And they're using that and they're selling it to surgeons in China to say this is an optimal or a good way to do lung surgery. And one of the surgeons said that I'm talking ourselves and all surgeons out of a job. And I said, no, we're not. We're increasing patient care. Anything that increases patient care is a good thing. And again, the surgeons think myopically. So I'm flattered that they picked me to be the one surgeon to do that, but we have a long way to go. Because even though that may show one particular way to do it, someone's lungs different, there's a lot of variety. But this eventually, in everyone's lifetime in this room, everyone, is an issue we're going to have to address. I can tell you I worked with a company 2 weeks ago on Saturday in London. I did an operation on Friday there in front of about 80 surgeons, gave a lecture, and then I partnered with a company about doing lobectomies with no incisions. What do you think about that, Gaitan? Down through the mouth, laser opens up the bronchus, you take the cap, you suck it in, the artery and vein are there, you can either percutaneously occlude them or have some other energy device, and then the only thing that's left is to get the tumor out, you put it in a bag, you put acid in it, you suck it out the airway, and you seal the cap over it. Maybe, I don't know. Problem with that is we don't get the tumor markers, but we probably could get them beforehand with all the things that Gaitan showed you with the bronchoscope, with biopsies. So is this the future? First of all, the rooms won't be that big, although in Kimmel, they're going to be gorgeous. And every room will be a private room. So you tell anybody who gets cancer anywhere in New York City that we're the only place that has a big, beautiful private rooms in the entire city, as far as I know, once we finish the damn building, which has some problems. I put this everywhere I go because a lot of people want to observe. Unfortunately, I don't think you guys can tune in and watch a lobectomy, but that gives you my email and my cell phone. You're welcome to email me or call me if you want to have some sort of event, anything that outreaches to patients with lung cancer. The answer is yes, I'm happy to go, and my charge is very little, it's zero. So this is my passion. I think everyone in this room's passion is to decrease the mortality and morbidity of people with lung cancer. The only way to do it is get actual education out there. And it's not just prevention. It's not just prevention of smoking and prevention of it, and not just early detection. It's all the things that you heard today. This is another way surgeons can come to our room, this thing called InTouch. We have the only InTouch on the East Coast. There's one other one now in the Midwest. There's only 2 in the US. They picked me, I'm the only lung surgeon doing it, and there's a general surgeon that uses it, and allows surgeons anywhere in the world to come in their OR without traveling. So now in the last 2 years, I have people who can come and watch us operate, put a little headset on, and I talk to them while I'm operating. And again, this is a credit to NYU to have this vision and also to market themselves as the best lung cancer center, not in New York City, in the world. The best lung cancer center in the world. That's what we're known as in industry. Appreciate that. And that's because of the doctors you just heard talk. So I like when they tell us we're second or third in the city. I guess you guys aren't looking at the right placement. We're actually way by far the best in the city. I don't think anybody's close. We're talking, when you say we're the best in New York State, that is an insult, or the East Coast. We strive to be the best in the world, and we're going to continue to work to do that. But we already have that reputation, for sure, based on the visitors who come. So that leads me to this, and I thought this would be more fun than me showing slides. I was going to show a movie of a lobe, and then I heard people might not want to see what a lobectomy looks like. I think it's cool. It might gross them out because I'm close to lunch. So we'll talk about culture. So anybody know whose home this is? How'd you know it was my home, bro? So when you look at an institution and you see where they spend their money, it tells you what they value. So NYU has just put $1.5 billion in a hospital, all for patient care, all of it. So rather than show you a picture of Kimmel, this you remember better. This is a picture of my home. I have 3 boys. I'm into sports. I have a full-length basketball court. I got a 90-yard football field. I got a miniature golf course with 3 artificial greens. The world's best batting cage. All 3 of my boys played Division I college baseball. 2 got drafted. And I used to love to beat them in the swimming pool in laps. I can't anymore. So the point is, a culture is determined by this. It's not the mission statement you read on some damn website. That's a bunch of baloney. That's a bunch of guys sitting in the boardroom like me making something that looks good. It's who you pay, how you pay them, where you spend your money, and how you engage team members. Think about that in your own family. You're all going to be sitting around the table having Thanksgiving. Think about what you talk about. That's your culture. Think about what you report. How's Johnny doing, or Billy, or Sarah? What do you talk about? That's the culture you create. We want to create the best patient-centered focused culture, and I think we're on our way to doing that. And then you can write about it. And I've written a whole bunch of papers like our other speakers. We all have a couple hundred papers, big deal. But here's one way that aligns patients and hospitals. We can decrease the time to take your Loba, which is good for you. You're in the OR less. We can use the process of lean. I got my MBA 4 or 5 years ago. It's a way to save money. We can actually look at your hand movements and how the nurses are walking around and say you're walking around too much and design ORs to be more efficient. It goes on and on. And what's good about that? Work-life balance. And one of the biggest problems doctors have is they work 14, 15 hours a day and they have problems at home or difficulties at home. It's because we work so hard. And then the nurses get stressed out because we stress them out. I think if we did a better job there, our patients would do better if we had better work-life balance. So I will end talking about that because that applies to any audience I speak to. This is a study we did that said there were 59 things that I wanted to deliver to every single patient. Some of them were, if you called my office, you never got an answering machine, you always got a live voice. I had that when I was at Birmingham. We're working at that here in New York. We're not there yet, right, Gaitan? But we're going to get there. Number 2, if you call to see me, that I will either call you within 24 hours or see you within 4 days. That's something that we can do. The operations were easy. The operation was get all your cancer out, take all your lymph nodes, make sure that you were highly satisfied with your care. But it's more difficult in New York City than it was in Birmingham, where I showed you that house. We are space restricted. We have, everything is more expensive. You want to get a bagel. In Birmingham, it's $1. It's like $5 here. It's ridiculous. Why? I think it's all culture. I think it's all baloney. It's really not that expensive. Everybody is nickel and dime, and everybody else, everything goes up. But that's the reality of doing business here, and we have to deal with that culture. The point is, this was the first paper, and I don't even remember when it came out, 2011. So we started it in 2006, that looked at benchmarking quality. Now everybody talks about it. This is 15 years old for us, because we believe that the customer is the patient. And doctors don't look at it that way. They just look at, oh, I did a good operation. The patient doesn't give a damn if the operation is good. They were asleep. They have no idea what you did in there. They care about, did you care about them? Did you talk to them? Was their pain controlled? Was the food any good? How was the parking? And did the family have a good time, and could I sleep? Does anybody get a good night's sleep in the hospital? No. So we started a sleep hygiene program, and we're going to start that here. There's no reason that we need to wake you up at 2 in the morning and ask you how you feel. I said, I was feeling great till you woke me the hell up. Doesn't make any sense. This is what the robotic console looks like. So you see, it's an immersive thing where I'm sitting in a chair, looking in a box, moving my hands, and then the robot is 5 or 10 feet away over your body. We make tiny little incisions and put little instruments in and we manipulate them. You should start to think, do I need to be 5 feet away? Could I be 5 miles away? 500 miles away? Why can't I sit in my basement in my pajamas, I don't wear pajamas, but whatever, a gown, and a cup of coffee and operate? Well, you could. 20 years ago, they did an operation in New York City and Paris that way. But because of lawyers, and once again, we've allowed lawyers to dictate culture, we don't do that. I am going to start the very first remote proctoring ever done in the world, I think in 2 months, if I can get the NYU lawyers to sign off. That is not tissue manipulation. I will sit in this console and little arrows will show up on the screen for a doctor in Singapore, a good friend of mine who's going to do a lobectomy there. He's already done 100. He's already very, very good. But it'll be remote proctoring. That is clearly our future. But the real future is for him to switch the controls to me and allow me to actually interact in the tissue. There's a latency phase of the signal. There's some issues in the belly. It doesn't matter. In the chest, the heart's going up and down. Things move. So that latency phase may be real. We've already done it on animals. It seems to work. We don't use cables under the ocean like they did from Paris to New York. We use Wi-Fi, and what if the Wi-Fi goes down? There's issues. So of course there'll be doctors in the room, but that's so much cheaper than people flying in, or me going to London last weekend, Singapore a month before that. I go to Chile next Wednesday for 2 days. It's agony to go on these trips. I enjoy it, but spending more time in the airplane than being there teaching doesn't make sense. And then we can teach people where you make the incisions and how to do it, but we can't teach them quality. And we really can't teach them the things that resonate to patients, and that's to really care. And that's to show the patients you love them. And that's to show them that you're here for them. So I've been very disappointed that I coached 12 guys who were good surgeons, but one guy's a jerk. He is. Because one of the quality metrics I do now is I send surveys out to the nurses in the OR. And it's been 2 years, and his scores have been the lowest of all 12 people I coach. He's a big, famous professor at a big, famous institution that you all think is one of the best cancer centers in the world, and I don't think it is. Their open rate is 26%. That means if you go there with a cancer, you have a 1 in 4 chance they're going to make a big incision and spread your ribs. Do you know what our open rate here is for lobectomy? It's 1%. We have the lowest in the world by 15 percentage points because of Dr. Zervos and some other people that do robotic surgery here. So we can teach this, but this is just the technological aspect of it. This is just the where you put this, where you put that. It's the other things that make or break patient care and the things that we need to work on as people, and God knows I need to work on it too. I'm honored that I've been, credentialing and training people, because that's the next issue, is how do you credential? The hospital buys an expensive robot and they want to use it. And the doctors want to say they can use it, so what do? You go to a weekend course, you sleep at a Holiday Inn, and now all of a sudden you're an expert? I don't think so. But of course, that's the incentive, and that's part of the problem with any new technology. So going through our surgical society, I chair the AATS Robotic Fellowship, which means we sign off on fellows if they can do it or not, but the problem is they're going back to hospitals where they do very little robotic surgery, and they're not getting enough volume to do it because the professors haven't done enough. The average median number is about 20 cases. I've done 1,700. Dr. Zervos here has done over 1,000. We have Dr. Spears, who's out in Long Island, who's part of the NYU family now. The three of us are the top 10 robotic surgeons in terms of numbers in the world, and we're all at NYU. And there are great surgeons at other places in New York City who are great friends of mine as well, and I have great respect for them. But of course, I'm talking about NYU today. Training and credentialing is the key because that's the only thing that protects you, the patient. And patients don't know. They think they go to a place because of the name on the door, and the name on the door is great. It doesn't mean they're getting a great surgeon. And the internet can't tell you that. What you should really ask is who has done the most in this area? And that is a surrogate of quality, volume. Who's done the most? Because that means him and her team has a team that can take care of you. And so I would sum up saying, this is something I tell my kids every day. I mean, look at me. I'm not tall. I'm not very smart. I'm not real good looking. My wife was. My wife passed away 5 years ago from cancer. So for everybody in this room, I know what you've been through. I slept at her bedside for 4 months, operating all day, and then sitting up there. And she's like, who's taking care of the kids? I said, the hell with the kids. They're 14, 12. They were, my son was at Yale. So he was a freshman at Yale and a sophomore at Yale. My other son was a senior in high school. My other son was a freshman. They were old enough to take care of themselves, 2 in high school, 1 in college. And I said, they'll be fine, because my world was my wife. She got breast cancer, and she got chemo, and the chemo caused the leukemia. And then 2 years later, she passed away from leukemia. And so, fortunately, because my children had, their mother gave them half their genome, They're at least 6 feet and a little bit smarter than me, but not much, actually. But this is one thing I do think we taught them. And I invite you to put this and instill this into your children, into your families, into the cultures where you work, and that is, what do you create in your operating room and at home? Are you really creating a culture where you value everybody? Are you really creating a culture where you love everybody? Are you really treating them like your children? You know, I always give the example when an 11-month-old starts to walk and the kid falls down, does everybody laugh and say, you're a loser? I mean, is that the response we have when watching someone trying to walk? Or is it incredible loving and nurturing? Come on, you can do it. Why don't we do that when the surgeon puts a hole in an artery or a vein? Why don't we do that when the nurse hands us the wrong instrument? So it really is a different perspective and culture. And really, everyone in this room can drive a culture. You just have to say, I want to do it. I'm proud of this slide because it gets bigger and bigger. This is where we've had visitors come over the last 8 years to watch our team operate. And it's unbelievable that people would fly. These are just the people who flew. These doesn't even include the InTouch remote system. And they bring their nurses, they bring their anesthesiologists, some have brought administrators. A couple of people have brought their friends, and I'm like, you know, this is not a city exhibit. You can just walk in here. I mean, they weren't even doctors, but I appreciate that. I mean, I'm glad that they're showing industry. I also think how you can drive teams. And I do think that's what makes excellence, and that's what makes NYU, the nurses on the floor and everything, something that's really special, and why I came here, along with the two previous speakers. They are world-class doctors who not only are great in the lab, but are really, really good people and really love their patients, and that's what attracted me. And so I would close saying, you know, as surgeons, I could ask Gaitan, now she's a great mom, so she's not a perfect example, but how many bronchs did you do last year? How many cases did you do last year? How much? 650. And then I do inspirational speaking. I just was as a Google about 4 months ago. Everyone in that room had to make $15 million. So these were big time vice presidents. And I asked them how much they made last quarter. I said, how many times did you take your wife out to dinner? Or how many of your kids' events did you miss? Now, Gaitan, you don't miss any of your kids' events, but she's a bad example. But do you record that? So I started thinking about that's what my first book was about. It was about really recording the things that matter. Yeah, I'm a doctor, and yes, I'm a surgeon, but I was a husband first. Really, I was a son first, and my parents are still alive. It's one of the reasons I also came back to the Northeast. My parents live in New Jersey. So I was a son first, then I was a husband, then I was a father. And you know, everyone sees their kids as unconditional love. Well, so is your spouse. Hopefully if you can make that last, like I did for 21 years, it was too short, but it was great. But I wasn't recording the things that mattered. So I started recording these things. So think about what culture you want to create at home. What do you value? If you really value your kids, do you record how many of their events they miss, or how many times you had dinner together, et cetera? And then I started measuring my 3 knucklehead boys. And like the fighting, I said, can we go 1 week, you idiots, and not have a fight? 1 week. Couldn't do it. Couldn't do it. Literally, they couldn't do it till the oldest was about 14. And even though I showed them their scorecards, they're like, Dad, we don't care. Okay, so not everything works, and you have to come up with different ways to maybe to punish them. And then I got very innovative on that, and that worked. But I think you measure the things that matter. And for us, it was grades, school, sports, all these other things. And then myself as a child, was I seeing my parents? I got a 1 out of 5 on that because my parents were in New Jersey. I was in Birmingham. Taking my kids to see my parents. I couldn't once they got busy. But then we started FaceTiming. We came up with novel ways. And that leads me to how we're seeing patients now. So we're setting up a telemedicine clinic where patients don't have to drive into New York or go to the cancer center to see us. You can if you want, but we'll see you at night on our telephone from 6 p.m. to 9 p.m. in the comfort of your own home with your family around you. You don't have to pay for parking. You don't have to pay and wait. In fact, I don't even think you have to pay me. At some point, we'll figure that out, but I don't care about the billing. Right now, I get in trouble for that, but that doesn't motivate us. It's about making sure you feel that we value you, we love you, we come to you, and we provide you the best care. So with that, I'd say it's been an honor to be here, and I appreciate all your time. Thank you.